This presentation is about all of the terms you see here. Most commonly, in my experience, among patients it's referred to as TMJ, but TMD is what you'll find it most often referred to among healthcare practitioners and researchers. But sometimes craniomandibular dysfunction, or CMD, is used to signify the importance of the cervical spine with pain and dysfunction in this area. I'm Nick Rainey, physical therapist. I initially created this for a project I needed for my orthopedic and manual physical therapy fellowship. I really enjoy treating people with TMJ-related symptoms. Regardless of what we call it, these TMJ-related symptoms, I want to set the stage for what we're going to accomplish with this presentation. But first, let's start with what it's not. This presentation is not a review of anatomy or biomechanics. Here we will focus on diagnosis and treatments available primarily by dentists and physical therapists. To start, we'll look at diagnoses. I base much of the diagnosis section off of the paper you see to the right here. Most of the authors have some type of research degree, either as a Doctor of Philosophy or a Master's of Science. Additionally, most are dentists, but there are a few physicians and one physical therapist. The dual axis model described in this was originally proposed in 1992, and after research, trials, and meetings, we now have the updated version that was published in 2014. You could spend a lifetime studying the knowledge these experts packed into this. For this presentation, I'll describe the dual axis system, but you should download this paper on your computer for your reference, which is open access and can be found online, or if not available for posting in the format you're watching this, you can email me and I'll send it to you. In the future, I will reference this paper as the RDC, short for Research Diagnostic Criteria. The dual axis system is wonderful because it actually focuses on both aspects of a biopsychosocial model. The first axis deals with the bio aspect. The following two slides you'll see the 12 axis 1 diagnoses. You'll notice I have the ICD-10 codes next to them. You should also note that while there are 12 common diagnoses described here, there are only 6 ICD-10 codes. With all of the myalgias having M7911, it should be noted that in the RDC, M79-1 is listed, but this cannot be used for reimbursement when billing. M7911 is myalgia of muscles of mastication, so I put the one that we can use in billing here in the presentation. All of the disc displacement disorders having M2663 with the remaining 4 ICD-10 codes in the column on the right of this slide. I'm going to spend some time here reviewing the main points of the diagnostic criteria for each. The first 6 I'll review are in italics and are the diagnoses related to pain. The final 6 I'll review have no pain as part of the diagnosis. So for the pain diagnoses, all of the myalgias, myofascial pains with the ICD-10 code of M7911, mean that there is no other anatomical reason for pain besides the muscles being painful. Temporalis and masseter muscles are palpated with a pressure of 1 kilogram for 5 seconds. This is the most common form of diagnosis of myalgias, but pain with mouth opening, which may be at end range, prior to end range, or with overpressure at end range, is also a valid objective test for diagnosing myalgias. And we have the last 2 pain diagnoses. Arthralgia is a diagnosis from the joint. This patient will have pain right at the joint with palpation, or with myalgia, pain with mouth opening, or with overpressure, or with lateral or protrusive movements. Headaches attributable to TMD is a diagnosis when the patient has a headache due to myalgia or arthralgia. Often headaches are multifactorial, and the patient may have headaches attributable to TMD, but also may have a tension type headache or cervicogenic headache, which is commonly seen. Degenerative joint disease must have crepitus or other noises with jaw movement and is validated by imaging. It's interesting to note that pain is not part of this diagnosis. Subluxation refers to the patient having both condyles of the mandible come anterior to the articular eminence, but the patient is able to reduce it on their own, normally with use of their hand, but some are able to do it without use of their hand. Luxation is not described here, but a luxation, also termed an open lock, and requires a clinician to reduce the condylar heads posterior to the articular eminence. These are the disc displacement disorders. Again, notice they all have the same ICD-10 of M2663. In the occlused position of the disc is displaced most often anteriorly, and when it opens, it will either reduce to between the condyle and the articular eminence, or it won't reduce and stay displaced. The first diagnosis listed here, the disc reduces always. The second one, it intermittently doesn't reduce, and thus locks and is unable to open completely. The last two, the disc doesn't reduce, but stays displaced. However, often the disc and retrodiscal tissue will adapt, allowing a return of normal opening. The extent of displacement cannot be known without MRI. As with other musculoskeletal conditions, imaging isn't recommended unless it will change the course of treatment. If failure to respond to therapy and unusual or concerning findings are noted clinically, then imaging is recommended. It should be noted that treatment only focused on treating disc signs is not considered medically necessary. Treating symptoms is considered medically necessary. However, treating disc displacement is often part of treating the symptoms. The Axis 1 diagnoses reviewed previously are the most common. However, not all TMDs that you see will fall within the most common diagnoses. There are also other congenital conditions, disease processes, or generalized pain conditions that can affect the TMJ. The details of each will not be discussed in this presentation. You can see a list of these diagnoses in Table 4 of the RDC paper I referenced earlier, or read the more details of each in Orofacial Pain, Guidelines for Assessment, Diagnosis, and Management, which is produced by the American Academy of Orofacial Pain. This is the conclusion of Part 1 of this series.